Good morning, students. In today's class, you are going to learn about clinical enzymology. In clinical enzymology, you are going to learn how enzyme can be used to diagnose several disorders. That is, enzymes of diagnostic importance. Second, you will learn how enzyme can be used in treatment. That is, therapeutic enzyme. Third, you will learn how enzyme can be used in the laboratory to estimate several analytes which is present in the blood. That is, enzyme as a reagent in clinical chemistry. Okay. So we'll start with the enzymes of diagnostic importance. In enzymes of diagnostic importance, we are going to learn how enzyme can be used to diagnose myocardial infarction first. Then how enzyme can be used to diagnose liver disorders. Then how enzyme can be used to diagnose acute pancreatitis and muscular disorders and bony disorders. And finally, how enzyme can be used to diagnose several tumors. That is, enzyme as tumor markers. So let's start with myocardial infarction. There are 3 enzymes and 6 proteins which are used to diagnose myocardial infarction. So in enzymes, we have creatine phosphokinase MB. Second, lactate dehydrogenase. Third, aspartate transaminase or aspartate aminotransferase. Coming to proteins, in proteins we have troponin T and troponin I, myoglobin, myeloperoxidase, glycogen phosphorylase isoenzyme BB, ischemia modified albumin, and last one, pregnancy associated plasma protein A. Let's see one by one. So we'll start with creatine phosphokinase MB. So first we have to discuss the reaction in which it is involved. So creatine phosphokinase, as the name suggests, kinase means it is going to transfer something. Phosphokinase means it is transferring phosphate. So it is going to transfer phosphate from ATP to creatine, resultant formation of creatine phosphate. Okay. So it is transferring phosphate from ATP to creatine, resultant formation of creatine phosphate. It is a reversible reaction. So when there is a need of ATP, the creatine phosphate is going to donate the phosphate to ADP, resultant formation of ATP. So that's why it is called a storage form of energy in skeletal muscles. So this is a chemical reaction. There are totally 4 isoenzymes. That is CPK1, CPK2, CPK3 and CPK4. Whether you are going to write it as creatine phosphokinase, that is CPK, or creatine kinase, CK, both are right. Okay. So here you can write on CPK1 or CK1. So it is made up of 2 polypeptide chain. Either it will be made up of M polypeptide chain or it will be made up of B polypeptide chain. So CK1 is made up of 2 B polypeptide chain. CK2 is made up of 1 M and 1 B. So it is called as MB. CK3 is made up of 2 M polypeptide chain. CK4 is made up of multiple M and B polypeptide chain. So you are going to write it as it is present in mitochondria. CK1 is present in central nervous system, that is in brain. So it will be elevated in CNS disorders. CK2 is present in cardiac tissues. So it will be elevated in myocardial infarction. CK3 is present in skeletal muscle. So it will be elevated in muscular dystrophy. CK4 is present in brain as well as in smooth muscle. So it will be elevated in CNS disorders. So these are the different isoforms and where it is located, when it will be elevated. So in which condition it will be elevated. So in myocardial infarction, CK2, that is CKMB, will be elevated. So usually we will measure total CK, that is all CK together, creatine kinase together, total CPK or CK, and we will measure CKMB, these two concentration. These two concentration will be elevated. So what is the reference value for these two concentration? The reference value for total CPK is 15 to 100 international unit per liter, and for CKMB is 5 to 25 international unit per liter. So you have to memorize these two. Okay, and both the methods, that is the method for estimation of total CK and CPK, is IFCC approved method. In myocardial infarction, CKMB or CPKMB will start elevating in the blood by 3 to 6 hours after myocardial infarction. Once a patient has developed myocardial infarction, following that after 3 to 6 hours, CKMB will start elevating in the blood, and it will reaches the maximum concentration by 18 to 24 hours, and it will become normal by 36 to 48 hours. You have to memorize this number. Okay, so CKMB will start appearing, that is it will start elevating in the blood after myocardial infarction by 3 to 6 hours, and it will reaches the peak by 18 to 24 hours, and it will become normal by 36 to 48 hours. So next, coming to lactate dehydrogenase. So first we are going to start with the reaction. So as the name suggests, this enzyme is going to dehydrogenate the lactate. So it is going to dehydrogenate the lactate, result in formation of pyruvate. That dehydrogenated, that is that removed hydrogen, will be taken up by NAD, result in formation of NADH2. So it's a reversible reaction. So the same enzyme, lactate dehydrogenase, can able to hydrogenate the pyruvate, which is obtained from NADH2 to form lactate. Okay, so this is the reaction. So in the previous class, we had learnt we have totally 5 types of lactate dehydrogenase. That is LDH 1, 2, 3, 4 and 5. Okay. So it is made up of 4 polypeptide subunit. Okay. Either it will be made up of M type of subunit or it will be made up of H type of subunit. Okay. So LDH1 will be made up of 4H polypeptide chain. LDH2 will be made up of 3H and 1M polypeptide chain, and LDH3 will be made up of H2M2. LDH4 will be made up of H1M3 polypeptide chain, and LDH5 will be made up of 4M polypeptide chain. Okay, and LDH1 will be present, that is, it will be secreted in cardiac tissue. So it will be elevated in myocardial infarction. LDH2 will be produced from RBC. So it will be elevated in hemolytic anemia. LDH3 will be produced from brain and kidney. So it will be elevated in meningitis as well as in condition related to brain and kidney malignancies. And LDH4 will be present in liver. So it will be elevated in liver related disorders. And LDH5 will be present in skeletal muscle. So it will be elevated in muscular dystrophies. So these are the different isoform and in which it will be elevated. Okay. So even though only LDH1 is elevated in this particular condition, we are going to measure total LDH. Okay. In general, we will measure total LDH. So LDH, if LDH is elevated, it means it can be due to myocardial infarction, hemolytic anemia, malignancy, liver disease, or muscular dystrophy. Okay. So I told you in the previous class, in healthy individual, LDH2 concentration will be higher than that of LDH1. But in case of myocardial infarction, LDH1 concentration will become higher than that of LDH2, which is called as flipped pattern. So in flipped pattern, normally LDH2 will be higher than LDH1, but in flipped pattern, that is in myocardial infarction, it will be reversed. That is LDH1 will be higher than LDH2. Okay, and I told you LDH3 will be elevated in meningitis. Okay, LDH3 will be elevated in meningitis, and the reference value for LDH is 100 to 200 international unit per liter. And the method of estimation is DGKC method. So LDH following myocardial infarction will start elevating in the blood by 6 to 12 hours, and it will reaches the peak by 24 to 48 hours, and it will become normal by 6 to 8 days. So next, coming to aspartate transaminase. Aspartate transaminase is involved in transamination reaction. Okay, as the name suggests, it is going to transaminate the protein, that is transfer amino group from aspartate. That's why it is called as aspartate transaminase or aspartate aminotransferase. Okay, so this enzyme is going to remove an amino group from aspartic acid to alpha ketoglutarate. It is going to transfer it to alpha ketoglutarate. Okay, so once the alpha ketoglutarate has obtained that amino group, it will become glutamic acid. Okay, it will become glutamic acid. Once this aspartic acid has lost the amino group, it will become oxaloacetate. Okay, so that's the function of this enzyme, and this enzyme require PLP, pyridoxal phosphate, as its coenzyme. So we have two isoform for AST. One is cytoplasmic and one is mitochondrial. Okay, the tissue of origin, that is, it is present in liver, cardiac muscle, skeletal muscle, and in kidney in high concentration. And in a very low concentration, it is also present in pancreas and RBC. The reference value for total AST, that is including cytoplasmic and mitochondrial, which is getting secreted into the blood, in the normal individual, it is 8 to 20 international unit per liter. Okay, and the method of estimation is IFCC approved method. AST will start appearing, that is, it will start elevating in the blood by 24 to 36 hours, and it will reaches the peak by 4 to 5 days, and it will become normal following myocardial infarction by 10 to 12 days. So we had seen about the enzyme. Next, we are going to see only about the time of elevation for troponin and myoglobin. So troponin will start appearing, that is, it will start elevating in the blood by 4 to 6 hours, and it will reaches the peak by 24 to 48 hours, and it will become normal following myocardial infarction by 8 to 14 days. The reference value for troponin I is less than 0.12 microgram per liter. The reference value for T is less than 0.01 microgram per liter. Next, coming to myoglobin. Myoglobin will start elevating in the blood following myocardial infarction by 1 to 4 hours, and it will reaches the peak by 6 to 7 hours, and it will become normal by 24 hours. Okay, so this timing at which the protein as well as the enzyme which will start elevating in the blood following myocardial infarction, and when it will reaches the peak and when it will become when will come back to its baseline has been asked as a separate 5 marks. So this timing for whatever the enzymes and the protein which I shown for this myocardial infarction is important. You have to memorize it. Okay, that can be asked as a separate 5-mark question. Okay, so let's revise. So the first biomarker, first marker in myocardial infarction which will get elevated is myoglobin. Okay, so myoglobin will start appearing in the blood, that is, it will start elevating in the blood following myocardial infarction by 1 to 4 hours, and it will reaches the peak by 6 to 7 hours, and it will become normal by 24 hours. Following this, CKMB will start appearing in the blood, that is by 3 to 6 hours, and it will reaches a peak by 18 to 24 hours, and it will become normal by 36 to 48 hours. So following CKMB, troponin will start appearing in the blood by 4 to 6 hours, and it reaches the peak by 24 to 48 hours, and it will become normal by 8 to 14 days. Following troponin, LDH will start appearing in the blood, that is by 6 to 12 hours it will start elevating, and it reaches the peak by 24 to 48 hours, and it will become normal by 6 to 8 days. And the last one, AST will start appearing in the blood by 24 to 36 hours, and it reaches the peak by 4 to 5 days, and it will become normal by 10 to 12 days. So these are the markers for which you have to remember the time at which it will start appearing in the blood, and when it will reaches the peak, and when it will become normal. Okay, so you have to draw this graph which with labeling the timing for each of this marker. You have to draw with different colors, and you have to mention which is which marker, and you have to mention the timing at which it will start appearing in the blood, when it will be reaches the peak, when it will become normal. So to summarize, we have 3 enzyme and 6 protein which is used as a marker for diagnosis of myocardial infarction. So among these 9 markers, which one will get elevated first? The answer is myoglobin. Okay, and among these 9 markers, which is the most sensitive marker? So this is one of the frequently asked question. Among this 9, which is the most sensitive marker? The answer is troponin T and troponin I. Okay, troponin is the most sensitive one. Among the enzyme, which is the most sensitive one? If the question is asked like this, then the answer is CPKMB. Okay, CPKMB. Okay, I'll repeat. So among this 9 marker, which is the most sensitive one? Then the answer is troponin. Among the 3 enzymes, among the enzymes of myocardial infarction, which is the most sensitive one? Then the answer is CPKMB or CKMB. Okay, so that's all about myocardial infarction. So next, coming to liver disease. So to understand how to differentiate different type of liver disease, that is different type of jaundice using enzyme, first you should know about the jaundice. To understand about jaundice, first you should know about the hemoglobin catabolism. Okay, so first I will explain about the hemoglobin catabolism, then I will explain about the jaundice, then you will see about the enzyme which is used to diagnose different type of jaundice. So coming to heme catabolism, RBC has an half-life of 120 days. Once that 120 days is over, the RBC will rupture. From the RBC, hemoglobin will be released. So this hemoglobin which is released will get catabolized to form heme and globulin. This heme will get catabolized to form an water insoluble substance called as bilirubin. Okay, this water insoluble bilirubin is called as unconjugated bilirubin or indirect bilirubin. Okay, this bilirubin is water insoluble, so it will be transported by albumin to liver. Since it is water insoluble, it need a transport vehicle, that is albumin. So albumin is going to transport this unconjugated bilirubin to liver. Once it has reached the liver, it will get converted to form an water soluble bilirubin. Okay, That is how we are going to convert a water insoluble bilirubin to a water soluble one by adding and substance, that is by conjugating and substance, that is called as UDP glucuronic acid. By adding UDP glucuronic acid, we can able to convert unconjugated water insoluble bilirubin into a conjugated direct bilirubin which is water soluble. Okay, why it is called as conjugated bilirubin? Because we had conjugated the bilirubin with UDP glucuronic acid. Okay, so now it has become water soluble and now it will enter the duodenum. In the duodenum, further it will get catabolized to form urobilinogen and stergobilinogen. This urobilinogen will get converted to form urobilin, which is absorbed and which will be excreted by urine. Okay, so that yellow color of urine is because of the urobilin, and this stergobilinogen will get catabolized to form stergobilin and that will be excreted in the stool. So that's the one which is going to give color for the stool. Okay, so urobilin is the one which is going to give the color for the urine, and stergobilin is the one which is going to give color for the stool. So this is the normal heme catabolism. Okay, this is how normal hemoglobin will get catabolized. Okay, let's see what happens in jaundice. We have three types of jaundice. The first one is prehepatic jaundice. In case of prehepatic jaundice, there will be an increased RBC breakdown. When there is increased RBC breakdown, for example, in sickle cell anemia, thalassemia, in all this condition, there will be increased RBC breakdown. Then there will be increased hemoglobin released. Okay, so more amount of unconjugated bilirubin will be formed. So in prehepatic jaundice, unconjugated bilirubin level will be elevated. Okay, it will be elevated. Okay. Next, coming to post-hepatic jaundice. In case of post-hepatic jaundice, there will be an obstruction to the outflow. Okay, so the conjugated bilirubin is formed. In this scenario, the conjugated bilirubin, that is from unconjugated bilirubin, it has entered liver and it is getting converted to form conjugated bilirubin. Okay, this conjugated bilirubin is not able to reach the duodenum. Okay, it is blocked. For example, gallstone. Okay, since it is blocked, it will get reabsorbed into the blood. So blood level of conjugated bilirubin will be elevated. So in obstructive jaundice, conjugated bilirubin will be elevated. Okay. The third type is hepatic jaundice. In hepatic jaundice, both unconjugated bilirubin and conjugated bilirubin will be elevated. Okay. So we have three types of jaundice: prehepatic, hepatic, and posthepatic jaundice. In prehepatic jaundice, which type of bilirubin will be elevated? Unconjugated bilirubin will be elevated. In hepatic jaundice, both unconjugated and conjugated bilirubin will be elevated. In posthepatic jaundice, conjugated bilirubin will be elevated. Okay, so these are the three types of jaundice. Now let's see what are the enzymes will be elevated in these conditions. So the enzymes which is altered in liver disease, that is liver disease, or aspartate aminotransferase, that is AST. Okay, we can also write it as aspartate transaminase. Okay, both are right. Second, alanine aminotransferase or alanine transaminase. Okay, ALT. Third, alkaline phosphatase, ALP. Fourth, gamma glutamyl transferase, that is GGT. And the last one, 5-nucleotidase. So these are the enzymes which will be elevated in liver disease. Okay, so let's see one by one. So we are going to start with the aspartate transaminase. Okay, so we have already discussed about this aspartate transaminase. So aspartate transaminase, as the name suggests, it is going to transfer the amino group from aspartate. Okay, it is going to transfer the amino group from aspartate to alpha ketoglutarate. So aspartate will become oxaloacetate, and once the amino group is obtained from alpha ketoglutarate, the alpha ketoglutarate will become glutamic acid. Okay, so all the transferase require pyridoxal phosphate, that is vitamin B6 is required for its activity. Okay, that is, it is required as a coenzyme. So this is the chemical reaction. AST is present in both cytoplasm and mitochondria. Okay, it is present in very high concentration in liver, cardiac tissue, skeletal muscle, and kidney. Okay, so this is very important point. That is, AST is present in high concentration in liver, cardiac tissue, skeletal muscle, and kidney. So in this cells, in this tissue, both in the cytoplasm, in the mitochondria, it is present. Okay, it's a very important point. Okay, so it is present in very low concentration in pancreas and RBC. So why it is important to know this point? If AST is elevated, it means it can be due to liver damage, or it can be due to some cardiac tissue damage, or it can be due to some skeletal muscle damage, or it can be due to some kidney damage. Okay, so it can be any one of this condition. Okay, and ALP will be very mildly elevated in any pancreatic damage and RBC lysis. Okay, so it will not be that much elevated in these conditions. The reference value for AST is 8 to 20 international unit per liter, and the method of estimation is IFCC approved method. So next, coming to ALT. Okay, as the name suggests, that is alanine transaminase or alanine aminotransferase. Okay, so this enzyme is going to transfer the amino group from alanine to alpha ketoglutarate. Okay, so once the alpha ketoglutarate has obtained the amino group, it will become glutamic acid, that is glutamate. Okay, and once the alanine has lost the amino group, it will become pyruvate. Okay, so all the transaminase require pyridoxal phosphate, vitamin B6 as the coenzyme. Okay, so this is a reaction for ALT. So ALT is a cytoplasmic enzyme. Okay, so in AST we have seen it is present in cytoplasm as well as in mitochondria. Okay, ALT is present only in cytoplasm of liver. Okay, it is mainly present in liver. Okay, it is present in very high concentration in liver, and in a very low concentration it is also present in kidney and skeletal muscle and other tissues. Okay, so if ALT is elevated, it means it mainly due to liver damage. Okay, so compared to ALT and AST, ALT is a better marker for liver damage. It's a very important Viva question. Which enzyme is a marker for liver damage? Okay, which is a more reliable enzyme? So if this particular enzyme is elevated, then it indicate liver damage. Then that enzyme is ALT, alanine transaminase. Okay, so ALT is the more specific enzyme, more specific marker for liver damage. So AST and ALT both are elevated in liver damage, okay, liver disorders. But ALT is more specific. Why ALT is more specific? Because ALT in high concentration it is present only in liver. AST in high concentration it is present in liver as well as in other tissues like cardiac tissues. Okay. So ALT is more specific for liver damage. So in liver disease, that is patient with liver damage, both this enzymes will be elevated. But the concentration of ALT will be higher than that of the AST. That is ALT concentration will be higher than AST in case of liver damage, liver disease. So why it is like that? Because the half-life for AST is very short. The half-life for AST is very short. That is, it is only 18 hours. Okay. If you see ALT half-life, it is 36 hours. Okay, so that's why in liver damage, in liver disease, usually ALT concentration will be higher than that of AST. This is called as D-Ritus ratio. D-Ritus ratio. Okay, but in some condition, AST will be higher than ALT. That is, the AST-ALT ratio will be greater than 1. Okay, so those conditions are alcoholic hepatitis, cirrhosis, ischemic liver disease, and hepatocellular carcinoma. Okay, so these are the conditions where AST is higher than ALT. So why it is higher? That is why in this condition AST is higher than ALT, because I told you AST is present in both cytoplasm and mitochondria, right? So normally in rest of the liver damage condition, only the AST present in the cytoplasm will be released into the blood. But in this conditions, AST which is present in the mitochondria as well as the cytoplasm will be released. So compared to the ALT, it will be higher. Okay. So only in this condition, AST will be higher than ALT. So AST-ALT ratio will be greater than 1. Okay. This is very important. It's one of the frequently asked Viva questions. Okay. In which conditions AST and AST-ALT ratio will be greater than 1. In rest of the liver disorders, ALT will be higher than that of AST. Okay. So in rest of the liver disorders, ALT will be higher than that of AST. And by looking at the ALT and AST value, that is patient report, comparing it with the reference value, how many times it is elevated in this patient, comparing with the upper limit of the reference value, we can able to narrow down what is the most probable cause of this particular liver damage in this patient. For example, if ALT and AST both are elevated more than 15 times the upper limit, then it is severe elevation. Okay, and this severe elevation is seen in acute viral hepatitis A, B, C. It is seen in toxicity which result in liver damage. It is seen in ischemic liver injury. And if ALT and AST values in the patient is elevated 5 to 15 times the upper limit, then most probably the patient is having alcoholic hepatitis, autoimmune hepatitis. If ALT and AST values are 2 to 5 times elevated compared to the upper limit, then most probably the patient is having cirrhosis or NASH, that is non-alcoholic fatty liver disease, or carcinoma of liver, or Wilson's disease, alpha-1 antitrypsin deficiency, hemochromatosis. Okay. So any one of this condition can result in 2 to 5 times elevation of the AST into ALT up to upper limit, that is 2 to 5 times of the upper limit of the reference value. And if it is elevated borderline, that is only 2 times it is elevated, AST and ALT, then most probably the patient is having chronic viral hepatitis B and C. So we are seeing the reference value for AST, that is 8 to 20 international unit per liter, and ALT for male it is 13 to 35, and for female it is 10 to 30 international unit per liter. Both the analytes are estimated by IFCC approved method. So next, coming to alkaline phosphatase. Alkaline phosphatase, as the name suggests, it is going to remove the phosphate it will work only in alkaline environment. And from which molecule it is going to remove the phosphate? From nucleotide and glycerophosphate. Okay, and it is a metalloenzyme, so it requires zinc as its non-protein part, and it belongs to hydrolase group of enzyme. So there are totally 6 subtypes which we had already discussed in isoenzyme. So ALP, we have alpha 1 ALP, alpha 2 heat labile and heat stable ALP, pre-beta ALP, gamma ALP and leukocyte ALP. So alpha 1 ALP is produced from the endothelial cells of the biliary canaliculi. So it will be elevated in obstructive jaundice. Okay. Alpha 2 ALP is produced from liver. So it will be elevated in liver disease, that is hepatitis. Okay. Alpha 2 heat stable ALP is produced from placenta, so it will be elevated during pregnancy, and if it is reduced during pregnancy, it means placental insufficiency. So in placental insufficiency, ALP will be reduced, it will not be elevated. Okay, and in pre-beta ALP, it is produced from bone, that is osteoblast. So it will be elevated in condition related to bone disorders, that is rickets, Page's disease. Okay, gamma ALP is elevated in produced from intestinal cell, and it will be elevated in ulcerative colitis. Leukocyte ALP will be produced from leukocyte, so it will be elevated in chronic myeloid leukemia. So these are the different types of ALP. So in case of jaundice, that is in obstructive jaundice, ALP will be elevated, and in hepatic jaundice, ALP will be elevated. So the reference value for adults for ALP is 40 to 125 international unit per liter. But in children's, it will be higher than this. Why it is higher than this in case of children's? Because in children's, they are growing, actively growing. So the osteoblast and osteoclast will be active. Since osteoblast is active, it is going to produce more amount of alkaline phosphatase. So compared to adults, in children's, ALP concentration will be higher. Okay, coming to the interpretation, ALP will be elevated 2 to 4 times in case of parenchymal liver disease and intrahepatic obstruction. It will be elevated more than 4 times in extrahepatic obstruction. It will be elevated in 10 to 12 times compared to the reference value in primary biliary cholangitis. It will be elevated 10 to 25 times in bony pathology. Okay, always remember, if it is more than 10 times, most probably it is bony pathology. So the method of estimation of ALP is IFCC approved method. Next, coming to gamma glutamyl transferase. So this gamma glutamyl transferase is produced from biliary duct of liver, kidney and pancreas. Okay, and it is involved in glutathione metabolism. There are 11 isoforms. No need to remember the different types and where it is present. Okay, just remember there are 11 isoforms. Okay, and the reference value for total GGT is 10 to 30 international unit per liter. Okay, and it is mainly elevated in very high concentration in alcoholic condition. Okay, so it is mildly elevated in hepatic and post-hepatic jaundice, and it is markedly elevated in alcoholic induced liver disease. Okay, it is mainly elevated in alcoholic induced liver disease. Coming to the last one, 5-nucleotidase. 5-nucleotidase is involved in catabolism of urine. It is elevated in intra and extrahepatic cholestasis. Next, we'll see about enzymes involved in detecting pancreatic disease. That is, enzyme used to diagnose acute pancreatitis. Amylase and lipase. So these two enzymes are elevated in acute pancreatitis. Okay. So these two enzymes require calcium for its activity. So both the enzymes require calcium for its activity. Amylase is involved in carbohydrate digestion. Okay. Amylase is involved in carbohydrate digestion, and lipase is involved in lipid digestion. Okay. It is involved in lipid digestion. Okay. Amylase is produced by both salivary gland as well as by pancreas. Lipase is produced only by pancreas. Okay, so that's why lipase is a better marker of acute pancreatitis, because if amylase is elevated, it can be due to some salivary gland infection, that is parotitis, mumps, or else it can be due to pancreatitis. Okay, that is acute pancreatitis. But if lipase is elevated, it is purely due to acute pancreatitis. So lipase is a better marker than amylase. The second reason is that lipase has a longer half-life. Okay, lipase has a longer half-life. That is, it will remain elevated in the blood for 7 to 14 days, and in case of amylase, it will remain elevated in the blood for only 2 to 4 days. Okay, and the reference value for amylase is 50 to 120 international unit per liter, and the reference value for lipase is 50 to 175 international unit per liter. And the method of estimation for amylase is CNP-G3 method, and for lipase it is Risosrofin method. That's all about acute pancreatitis. Next, coming to enzyme which is elevated in muscle disease, bone and tumor marker. So in muscle disease, muscle disorders, aldolase and CKMM will be elevated. In bone disorders, alkaline phosphatase and acid phosphatase will be elevated, and prostate specific antigen PSA is used as a marker of prostate cancer. That is, it is a tumor marker. So that's all about enzymes of diagnostic importance. Next, coming to the enzymes of therapeutic importance. At least you should memorize 5 examples for therapeutic enzyme. That is, enzyme used as treatment. Okay. So the important examples are streptokinase, urokinase, recombinant tissue prothrombin activator. So all these 3 are given as thrombolytic agent. That is, when a patient is having myocardial infarction, for that as a treatment we will give either streptokinase or urokinase or recombinant tissue prothrombin activator. And ribonuclease can be given as a treatment as antiviral drug. Adenosine deaminase can be given treatment for severe combined immunodeficiency disorder. That is, in this disorder, adenosine deaminase enzyme will be defective. It will not be produced. Next, coming to enzyme as reagent in clinical chemistry. So to estimation of glucose, we'll use glucose oxidase enzyme, peroxidase enzyme, and hexokinase enzyme. For estimation of urea, we will use glutamate dehydrogenase enzyme and urease enzyme. For uric acid estimation, we will use uricase enzyme. In ELISA, we will use alkaline phosphatase enzyme. And recombinant DNA technology, we'll use restriction endonuclease. And in PCR, we'll use Taq polymerase. So these are the enzyme which is used in some of the estimation of techniques. So at least you should remember for analysis, that is for estimation of analysis using enzyme, you should know what enzyme is used for glucose, urea, protein and uric acid. Okay, at least this 4 you should know. So that's all about clinical enzymology. So we had learnt about enzymes of diagnostic important, therapeutic important, and enzyme which is used in the clinical laboratory to measure the analysis of analytes which is present in the blood. Thank you.